Hello, I'm Bernard Gersh from the Mayo Clinic, and we are here for a roundtable discussion today with two of my colleagues, Dr. Malcolm Bell, who's Professor of Medicine at the Mayo Clinic, and Dr. Mackram F Eleid, who is a member of our cardiovascular fellowship program. And our topic today is really to deal with radial versus femoral artery access in patients with ST elevation myocardial infarction. And this was the subject of a recent review in JACC Interventions published in November. And Malcolm, I was kind of quite struck with the title, where you had a subheading that said, "A Call to Arms." I mean, that's pretty cute, actually, but well, given the radial is in the arm, isn't it?
Yes, yeah. So no coincidence there. No, we actually gave that some thought. I think it was a really just an attempt to really get people's attention. And as so often happens, you read a title and something catches you there. So we thought that it's very relevant. And
do you think this is something that has not had enough attention?
Absolutely. I think we're seeing more published recently, more discussion. But in terms of actually bringing it into your practice, I think we still have a long way to go. And so we thought that this was a great opportunity to really showcase and to highlight the technique and the data. And Mac, put together a beautiful argument in favor of the transradial approach. And we're talking about STEMI.
Yeah, I think it's important to make, and that this is not elective angioplasty, it's STEMI. So, Mac, what are the advantages? And obviously I'm going to ask you what the disadvantages are, but let's start off with the advantages.
Sure. Well, there's been several studies now, 3 randomized controlled trials and meta-analyses and also registry studies that all show that access site-related bleeding is reduced with the transradial approach in STEMI. Generally that's hematomas, vascular complications like pseudoaneurysm, those types of things. And several of the studies have also shown that mortality is reduced as well. So in-hospital mortality is lower in patients with the transradial approach.
So that's, I mean, I think it's very understandable why the hemorrhagic complications are less, but it really is, you're making the argument for the fact that the mortality, that these bleeds are responsible for an increase in mortality. And there's always been this discussion back and forth. Is it the bleed that is it cause and effect? Is it just that people that bleed are more fragile, they're older, they have other problems, or is it bleeding itself that reduces mortality and that increases mortality? And the fact that these 3 trials have shown a reduction in mortality would certainly suggest a cause and effect relationship with bleeding. Would you agree with that?
I think it suggests that, and there is still some uncertainty about the exact mechanism, but we know that bleeding is tied to mortality in patients with acute coronary syndrome, and there's more reduction of medications, so some of the antiplatelets will be discontinued, and then also some of the clotting cascade is activated when bleeding occurs, so that could play a role in the mechanism potentially.
Yeah, the other factor is that people who bleed get transfusions, and transfusions are not good for you.
Right.
That could be another complicating factor.
Definitely.
What was the extent of the reduction in mortality in these trials?
Well, there was a 1% absolute risk reduction in mortality in the RIVAL study, and then I believe the RIFLE STACS had about a 4% absolute risk reduction in mortality.
Yeah. Are you surprised by that?
Well, I think if we just go back to your original question, Bernard, about the bleeding, we've known about the link bleeding to mortality for a number of years now. And we've always struggled trying to work out what is that link, how is it related? And I think there's a lot of confounders, and I think you've already brought up some of the important issues here. And but here we now have an intervention. It's a technique. It's not a drug, but it's a technique that has shown a significant reduction in mortality. Sorry, a reduction in bleeding, which then has led to a decrease in mortality. And if we think about those numbers, I think that perhaps we shouldn't be too surprised. There's still a concern there about is it the patient that's really at high risk of bleeding, so they have a higher risk of mortality? I don't think we can answer that, certainly not today. But if we think about those absolute differences, let's put it in other numbers. The number needed to treat, to save a life in those trials and the meta-analysis is about 50 patients.
So
that's substantial.
That's substantial.
And we're talking about number needed to treat probably to decrease a major bleed and to save a life. Again, about 40 to 50 patients.
That's very substantial and very impressive. And I mean, that really is. If you look at that in the light of many other current treatments, I mean, that's a big difference. So what are the disadvantages? I mean,
yeah.
Obviously, we'll get into why it's taken us so long to get to this point, but what are the drawbacks or potential drawbacks?
Yeah, historically, there's been a lot of reluctance to use the transradial approach for STEMI patients because of the longer procedural duration and then the higher amount of experience required to use the transradial approach, and then also perhaps more delays in door-to-device time. But all of these studies and
what sort of magnitude?
Right. The magnitude is, well, the
magnitude of time of prolongation with the radial technique.
In the NCDR registry that just came out, the data from NCDR, there was about 4-minute reduction or 4-minute increase in the door-to-device time with transradial.
But that shouldn't make a difference now. Right now, door-to-balloon or door-to-device times are so low. I mean, have shortened so much nationally that we've got room to play with. I mean, I can't believe that 4 minutes would make a difference.
And similarly, we've seen here that door-to-balloon time, again, recent analyses haven't really shown that it's decreased mortality. But, but this is perceived as one of the disadvantages. And again, I think that's one of the points to make here. We're not really talking about a 3 or 4 minute difference. But this is an experienced hands.
You did allude to the fact that it's more difficult. There's a learning curve.
Right. And that's one of the points that we were trying to bring out, that kind of a call to action, that we that we raise awareness that this is it appears to be a safer technique, and so that we start using it more for more basic cases, and then slowly graduate up to the ACS patients as well. And I think the experience in our cath lab has been that experienced operators in the femoral approach will adopt the transradial approach pretty quickly. They master those skills quickly.
Yeah, but I mean, I accept that, but we also have to accept it's taken us an awful long time to get to this point. I mean, even with elective PCI, I mean, the radial approach was being advocated, what, 15 years ago?
Oh,
for elective, more than that?
20 years.
And for STEMI. And it is, for instance, the use of the radial approach has been far more widely used in Europe than it has in the United States. And some of the very early work in North America came out of Canada, not the US, from Edmonton, I think, were one of the first very large series of the radial approach. So what is it about the US that's really resulted in, has created this delay?
Well,
I mean, for a long time, people have been, it's always come out, well, we do it in Europe, why don't you?
Mm-hmm. Yeah, I think the reasons aren't completely clear, but we think that, for one thing, that there's not a lot of, not all training programs train in the transradial approach, for one thing. And there's still a lot of concerns from people out in practice about whether or not transradial is feasible for STEMI population. There's concerns about not being able to use larger guide catheters, only having up to 6 French available, things like that.
I think some of the equipment that has been available in some of those countries was in advance of what was available here.
Oh, really?
So that really changed things. So when we first started doing radial approaches, the introducer sheets, for example, the big problem is avoiding spasm. And I think we've pretty much overcome that in most patients now. But as usual, there's always a lag of getting that equipment into this country. But I can't really guess at what the difference is between the European interventional cardiologists and the U.S. interventional cardiologists. It may be just a coincidence. It may be that in a few pockets, or a few places in Europe, they really had physician champions of this technique and really pushed it. And it just happened to be the right people in the right place with the environment that was prepared to accept change. And I think we see this a lot, you know, in other areas of medicine. And
yeah, it must be, because, I mean, U.S. physicians and interventional cardiologists are not conservative by nature. I mean, you know, they're aggressive, and they're aggressive in adopting new approaches. So it's interesting that there's been this really big lag period.
Yeah, and Bert, in fact, I can tell you that in our own lab, you know, now we have tremendous support, particularly from our allied health staff. But when we first started trying to adopt this, there always seemed to be some barriers in it, you know, just to get this change. So you really need to have people who champion this. And I think generally this does come from younger individuals as well. But
do you think that I do want to leave some time for some discussion about the patients who should not have the radial technique, but before we get there, do you think it would be appropriate or defensible to not train people in the radial approach in interventional training programs in 3 years' time? I mean, do you think every program will offer this, should offer this?
Should, I think. It's a great question, and I think, and in fact, we addressed this to some extent in this article. I think that certainly among our you know, junior colleagues and trainees, I think it's become an expectation that they're going to learn the transradial approach. I think it's important.
When you get randomized trials showing a reduction in mortality and a reduction in bleeding, it seems almost inconceivable that one can ignore that.
So I think that, absolutely, and we would agree 100%, but I think that we've got to be very careful that we don't say that transradial is just taking over from transfemoral and the transfemoral approach is dead. I mean, there are times that you would use, and we can talk about this in a few minutes. So I think it's important that you're properly trained in both approaches. But I think to make the point here, what if this, if you go back to the question about decreasing bleeding, decreasing mortality, think about if this were a drug.
Yeah.
And you showed number needed to treat was 50.
Yeah.
And you're seeing, you know, 40, 50, 60% reductions in these major endpoints. We want to be using that drug. And it would already be in the guidelines. And currently, this is not even in the guidelines. Yeah, and so I think it's really fascinating. And that was the reason, you know, we can be perhaps provocative here, but I think we need to have people talking about this more.
So it's going to be time to change the guidelines. I think clearly can't be ignored. Can you just, a few words of caution just to finish off. We've got just a couple of minutes left. Who should not be treated with a radial approach?
Sure. Well,
right from the get-go.
Right from the get-go. I think in patients that are the advanced elderly, there's going to be a higher risk of significant tortuosity in the arm vessels that may make an operator want to start up front with a femoral approach. And then the other issue is the patient that comes in that's already in cardiogenic shock. Now there's still an argument for transradial in that population as well, and putting in a support device simultaneously from the femoral approach. But what are your thoughts?
What about people with peripheral vascular disease?
I think there always a challenge whether it's femoral or transradial. But I think that Mac is absolutely right. You know, the very elderly, these are the ones that become, you know, a little bit more of a challenge sometimes. They may have arterial anomalies, a lot of tortuosity. In some high volume transradial labs, you know, they'll routinely go from the left arm. But you know, just remember, these are some of the highest risk patients. These are the elderly patients. They're at higher risk, and so I don't think we should just automatically go and do a femoral approach on them. I think what we need here is just some common sense. You need to be experienced in this technique. This is not something that you learn overnight and start doing STEMI cases. But in experienced hands, you know, I think it's very reasonable to start with a radial approach. And if it's clear that you're running into problems, you know, there should be a certain time that you say, okay, we're going to stop and we're going to go to the transfemoral or the other radial. Who else perhaps shouldn't have this? We talked about cardiogenic shock. Again, we typically, our high volume operators will go transradial and leave the femoral approach for a support device if needed. And I think the patient who, I mean, clearly doesn't have a radial pulse, I mean, that's the same femoral, of course, or someone who's got multiple bypass grafts, and those cases clearly take longer from the transradial.
Well, thank you both very much. Congratulations on the article. And thanks to our viewers. We hope you'll continue to watch these roundtable series, which appear on hot.org Medscape. Thank you.
Thank you very much, Bernard.